Good day everyone, good day Ma'am Abby, and for today's video I will be going to discuss everything I've learned from the prelims up to the finals. So to start with, we are going to talk about what pharmacology is. So pharmacology studies how substances interact with living organisms through chemical processes, often by affecting regulatory molecules. So under pharmacology, there's a pharmacology that has a deliberate therapeutic application, which is the role of the um, medical pharmacology. So what is medical pharmacology? So medical pharmacology is concerned or is the study of using substances for the prevention, diagnosing, and for the treatment of diseases. On the other hand, toxicology is concerned with the harmful effects of the chemicals on an organism. Another thing, under pharmacology, we have pharmacokinetic. So what is pharmacokinetic? So pharmacokinetic deals with the absorption, distribution, and elimination of drugs in the body. And we also have pharmacodynamics. So pharmacodynamic deals with the action of the substances or the chemical to an organism. And since we are going to talk about drugs later on, let us first talk about its route of administration. So there are at least 7 routes of administration for taking drugs. So to start with, we have intravenous or IV, which has 100% bioavailability and it has the most rapid onset. Next, we have the intramuscular, which has 75 to less than or equal to 100% bioavailability. It has a large volume, it is visible, and it is painful. Next, we have subcutaneous, which has 75 to less than or equal to 100% bioavailability, and it has a smaller volume than intramuscular, and it may be painful. So kung ang intramuscular painful, kani siya smaller volume rani ang subcutaneous sa intramuscular, and kanang maybe painful lang kani siya painful. Next, we have oral. For oral drugs, oral route of administration has 5 to less than 100% bioavailability, and we all know that this route of administration is the most convenient. So next, we have rectal. So rectal route of administration has 30 to less than 100% of bioavailability, and it has a slower first pass effect. Then next, we have the inhalation, which has 5 to less than 100%, and inhalation route of administration has often very rapid onset. And lastly, for the route administration, we have the transdermal, which has 80 to less than or equal to 100% bioavailability, and it has a very slow absorption. Since we are talking about the route of administration, let us also talk about its safety tests. So we have 6 safety tests. So to start with, we have acute toxicity. So acute toxicity determines no effect dose and the maximum tolerated dose. It has no effect dose and no maximum tolerated dose for acute toxicity. Next, we have subchronic toxicity, which determines the biochemical and physiological effects. Next, we have the chronic toxicity, which is rodent and determines the same endpoint as subchronic toxicity test. Next, we have the effects on reproductive performance, which is for animal mating behavior, for their reproduction, for their progeny, for their birth defects, and postnatal development. We also have carcinogenic potential, which determines gross and histologic pathology. And lastly, we have the mutagenicity or mutagenic potential, which the test effects on genetic stability and mutations in bacteria, which is ginagamit siya for AIDS. Next thing we are going to talk about is the drug biotransformation. So in drug biotransformation, we have xenobiotic. What is xenobiotic? So xenobiotic is a foreign compound or foreign organisms wherein humans are exposed to daily. So since we talk about drug biotransformation, so drug biotransformation has 2 phases, the phase 1 and the phase 2. So phase 1 has a mnemonic of HOR, which stands for hydrolysis, oxidation, and reduction. So to start with, let's have hydrolysis. So under hydrolysis, there is an enzyme that is involved in the genetic polymorphism which causes defect. And that enzyme are CYP2C8 and CYP2C9. Another thing which undergoes hydrolysis are the esters. And under esters we have BCHE, which is the enzyme that is involved in the genetic polymorphism. Let's do it like this. And then lastly, which undergoes hydrolysis are the amides. So since we are done with the hydrolysis, let's move now to the second one. We're done with the H. Let's go with the O, which is the oxidation. So under oxidation, the same as hydrolysis, there are certain enzymes that are involved in the genetic polymorphism, and that enzymes are CYP2B6 and CYP2A6. That are the enzymes involved in the oxidation. The enzymes involved in the genetic polymorphism. So there are also enzymes that undergoes both hydrolysis and oxidation. These enzymes also are the same with these ones, but it has both the hydrolysis and the oxidation. So for both hydrolysis and oxidation, we have CYP2D6 and CYP2C19. Right after the oxidation, we are going to talk about the hydrolysis and oxidation. Let us now move to reduction. Under reduction, there are no enzymes, yet there are certain class of reduction. We have the nitro reduction, we have the azo reduction, and the carbonyl reductions. Not just that, under oxidation, we also have the cytochrome P450 dependent oxidation. We have aromatic and aliphatic hydroxylation. Next, for cytochrome P450 dependent oxidation, we also have epoxidation. After epoxidation, we also have oxidative dealkylation. We have the N, the O, and the S dealkylation. After the epoxidation, we also have after the oxidative dealkylation, we also have the N-oxidation, which are the primary amines, the secondary amines, and the tertiary amines. Put it here. And then we also have, for oxidation, we also have S-oxidation, we also have deamination, and we also have desulfuration, and that's it for phase 1. And now let's move on to phase 2. Let us talk about the conjugations present on phase 2. So to start with, we have glucuronidation, we also have acetylation, we also have glutathione conjugation, we have glycine conjugation, we have sulfation, we have methylation, and lastly we have water conjugation. So same as phase 1, there are certain enzymes involved in the genetic polymorphism. Just like phase 1, for phase 2, the enzymes involved are the UGT1A1, which is involved in the glucuronidation. The NAT2 is involved in acetylation. GST is for the glutathione conjugation. And lastly, the TPMT enzyme is involved in. So now we are going to talk about those enzymes also that are involved in genetic polymorphism in phase 1 and phase 2, but no specific whether it's oxidation, hydroxylation, reduction, or the different types of conjugation. Let's put it here. The enzymes involved in the genetic polymorphism in phase 1 and phase 2. These enzymes are CYP1A2, CYP3A5, CYP3A4, and the ALDH. That's it for the part 1 of our mind map. So next part, we are going to talk about the ANS and the drugs that are related to autonomic pharmacology. To start with its introduction, let us talk about the nervous system. So our nervous system has two major divisions, the central nervous system and the peripheral nervous system. But in today's discussion, we will just focus mainly on peripheral nervous system. Has two divisions also, the efferent and the afferent. So efferent means It is from the CNS to the periphery, while afferent means from the sensory to the CNS. So CNS to periphery, sensory to CNS ang afferent. So under afferent, there are two systems, the autonomic and the somatic. And then under autonomic, we have the sympathetic nervous system and the parasympathetic nervous system. And then, so our sympathetic nervous system is responsible for the fight or flight reaction, while our parasympathetic nervous system is responsible for the rest and digest parasympathetic nervous system, which has the cholinergic drugs. So in that case, there is a cholinergic transmission, which starts as choline enters the nerve terminal through a transporter, which is inhibited by hemicolinium, and then it goes inside the cell, and inside the cell, an enzyme which is CHAT uses choline and acetyl-CoA to create acetylcholine. So and then after it creates acetylcholine, a different transporter which is inhibited by Pcol packages acetylcholine into the storage vesicle. So after that, when a nerve signal arrives, calcium enters the terminal, and then which triggers the release of acetylcholine and other chemicals from the vesicles. And when that happens, botulinum toxin is released. It's released and is released, which blocks the release of the ACH and other chemicals from the vesicles. And after that, an enzyme, which is the acetylcholinesterase, breaks down ACH, which signifies the end. Before we move on to the drugs associated with the parasympathetic nervous system, let's now move on to the adrenergic transmission. So the adrenergic transmission starts with the tyrosine, which is being transported inside through the enzyme called tyrosine hydroxylase. And tyrosine hydroxylase is being inhibited by metyrosine. So from tyrosine turns into dopa, and then dopa to dopamine. And then right after that, dopamine enters the vesicle through the vesicular monoamine transporter, and then that dopamine turns into the norepinephrine, the ADP, and the P. So that VMAT, that vesicular monoamine transporter, is inhibited by the reserpine. And then, once the dopamine enters the vesicle, turns into NE, and then NE goes out. It goes out and turns into norepinephrine, and then it binds to the adrenoceptors. And then, in that adrenergic transmission, there are certain calcium channels wherein calcium ions enters, and there are also VAMPs and SNAPs present in the adrenergic transmission, and VAMPs and SNAPs are inhibited by the beryllium and guanethidine. So there is this NAT. So NAT that is present in the adrenergic transmission, which is inhibited by cocaine or the tricyclic drugs. Let us also talk about first the receptors. So receptors, we have the muscarinic receptors ranging from M1 to M5. We also have the adrenoceptors, namely the alpha-1, the alpha-2, beta-1, and beta-2. We also have the dopamine receptors, the D1,
the
D2,
cholinergic
D3,
drugs. So
and
we have here the cholinomimetic, mimetic. We have here bethanicol, which is on receptor M1 to 3. Next we have the carbachol, which is for M3 rather, M2, and then civimelin, which is for M3. Nicotine is for the NN, and then NM. Lastly, we have varenicline, which is for alpha, beta, and N. This alpha is for specifically for beta 2 and N. That are the cholinomimetic. These are the cholinomimetic. So these drugs, the bethanicol, the carbachol, the civimelin, nicotine, and the varenicline, are the direct cholinomimetic drugs. So since we are done with the direct, let's move on now to the indirect
Cholinomimetic
We have
drugs.
physostigmine, neostigmine, and then we also have pyridostigmine. We also have ambimonium. We also have demacarium, and so on. This physostigmine, neostigmine, pyridostigmine, ambimonium, and demacarium are the indirect reversible cholinomimetic drugs. So since we are done with the indirect, let's now move on to direct. Since now we're done with the reversible, let's now move on to irreversible indirect cholinomimetic drugs. Namely, they are ecothiophath, malathion, parathion, sarin, tabon. And since we are done with the cholinomimetic direct and indirect drugs, let's now move on to the cholinergic blocking agents. So you can see it here. So cholinergic blocking agents. So in the cholinergic blocking agents, we have the parasimpa post-ganglionic, post-G blocking agents, which includes atropine. So then under atropine we have hyoscyamine, and then next we have scopolamine. Under scopolamine we have homatropine. And then after that we also have ipratropium. Under ipratropium we have trotropium. So these are the three drugs under parasympathetic post-ganglionic blocking agents: atropine, which has hyoscyamine under it, scopolamine, and ipratropium. So since we're done with the post-ganglionic blocking agents, let's now move on to the synthetic cholinergic blocking agents. So let's have this abbreviated as synthetic cholinergic blocking agents, or SCBA. So under it, we have so many drugs. We have dicyclomine. We also have oxybutynin. We also have meperzolate. So under synthetic cholinergic blocking agents, we also have amino alcohols. Under amino alcohols, we have piperidine. We have procyclidine. We also have tolterodine and tolterodine. And then next to amino alcohols, we also have amino amides. Under amino amides, let's move it here. So under amino amides, we have isopropamide. We also have tropicamide. We also have dariphenacine. Lastly, for the synthetic cholinergic blocking agents, we have the classification of miscellaneous. Under miscellaneous, we have dipheranyl methyl sulfate. We also have papaverine. We also
HCl.
have non-depolarizing, non-competitive ganglion blocking agents. Under it are the drugs named trimetophan campylate, and mecamylamine HCl. Also, we have the neuromuscular blocking agents, which includes the drugs which has depolarizing blocking agents and non-depolarizing blocking agents. And
That's it for our cholinergic drugs.
And now let's move on to the sympathetic. So we have the adrenergic receptor agonist, 4A1 agonists. For A1, we have the mnemonics MONT ppm. M, which stands for methoxamine. O, that stands for oxymetazoline. N, that stands for nafazoline. T,
On to P now.
so P stands for phenylephrine. Phenylephrine. And here is another. And next is we have medodrine.
For alpha 2, we have the drugs clonidine, apraclonidine. Also, before I forgot, for alpha 1, we also have there the epinephrine, the norepinephrine, and the dopamine. Same as the alpha 2, we have the dopamine, the norepinephrine, and the epinephrine. So now, let us now move on to beta 1, which for beta, we have a non-selective beta agonist, which now, is since we are done with the alpha receptors in their drugs. Let's now move on to beta 1 receptors. Beta 1 receptor has a drug named dobutamine, and then we also have here the norepinephrine, the epinephrine, the dopamine, and its non-selective beta agonist, which has effect for both B1 and B2. We have the isoprotein, we have the PABA and the SABA. We have no, not PABA, it's LABA and SABA. It's long-acting beta agonist and short-acting beta agonist. So all in all, for beta 2, we have albuterol, we have terbutaline, we also have formoterol, we have metoprolol, we have ritodrine, we also have here the epinephrine, we have here the isoprolterenol, we have here the dopamine. So next we have B3, which has only one drug, which is the mirabegron. So before we move on to the sympathetic blocking agents, let's move forward to D1, which has phenyldopam. And then for D2, we have the alpha 1 blocking drugs, namely the zosines, the prazosines, terazosines, doxazosines, alphazosines, tamsulosin, and oxybenzamine. We also have phentolamine, we have labetalol, carvedilol, we have medroxalol, and bucindolol. So for alpha 2, we have yohimbine, corinanthin, we have mirtazapine, we have penoxybenzamine also, we have phentolamine. For beta 1, we have metoprolol, we have atenolol, we have betaxolol, we have nebivolol, we have esmolol, we have ciliprolol, we have temolol, medroxalol, we have propanolol, nadolol, we have labetalol, we have carvedilol. And for beta 2, we have butoxamine, we have labetalol, carvedilol, temolol, medroxalol, bucindolol, we also have propranolol, we also have nadolol. And for the beta blockers, for which has beta blockers, we have carvedilol, labetalol, propranolol, nadolol, we have cardiolol, we have penbutalol, we also have pindolol, we also have sotalol, and timolol. For MSA, we have propranolol, pindolol, acebutolol, labetalol, metoprolol. For cardioselective beta 1, we also have atenolol, we have metoprolol, acebutolol, we have betaxolol, we have bisoprolol, we have esmolol, we have nebivolol. Anti-hypertensive drugs, we have the diuretics, which has classifications of thiazides, loop, and spironolactone. So under thiazide, we have hydrochlorothiazide, and we also have chlorothalidone. For loop diuretics, we have furosemide. And for spironolactone, we have the centrally acting sympathoplegic drugs. Under it, we have clonidine and methyl-dopa. So clonidine and methyl-dopa both activates alpha 2 adrenoceptors. Another classification is diuretics. Nope, not diuretics. Let's move to the adrenergic neuron blocking agent. Under it, we have the drugs named guanethidine and reserpine. So, guanethidine interferes with the amine release and replaces norepinephrine in vesicles. It also has the similar effects and clinical applications to reserpine, wherein reserpine blocks vesicular amine transporter in noradrenergic nerves and depletes transmitter stores. So, reserpine reduces all sympathetic effects, especially cardiovascular, and it reduces blood pressure. And also, reserpine is used in hypertension, but in a kanang rare na kayo, like dili galit ko pero may rare lang, rare. We have the beta adrenoceptor blocking agents, BABA, which includes propranolol, which is a non-selective prototype beta blocker. We have metoprolol and atenolol, which are very widely used beta 1 selective blockers. Also, metoprolol blocks B1 receptors. Next, we have carvedilol. So, carvedilol, blocks, mo-block siya og beta receptor, then mo-block pod siya og alpha nga receptor. So, beta and alpha. And then, we also have nebivolol. So, ang nebivolol kay mo-release siya og nitric oxide. Next, we have the vasodilators like verapamil, wherein it is a non-selective block of type L or L-type calcium channel. We have diltiazem, which is similar with verapamil. We have hydralazine. We also have hydralazine causes nitric oxide release, the same as nebevolol. Diba, ang nebevolol kay kanang releasing of nitric oxide, same as hydralazine. After hydralazine, we have minoxidil. So, minoxidil kay metabolite opens K channels or potassium channels, nitroprusside or nitroprusside, which releases carbon dioxide. And then, we have the angiotensin converting enzyme or the ACE inhibitors. Like losartan or the artans, which blocks the AT1 angiotensin receptor. Next, we have the ARBs or the ARBs, which is the angiotensin 2 receptor blockers or the angiotensin receptor blockers. An example of which is losartan or the artans, which blocks AT1 angiotensin receptors. Next, we have the ACE or the angiotensin converting enzymes, which includes the captopril or the prils, in which it inhibits angiotensin converting enzyme. Captopril inhibits angiotensin converting enzyme. Lastly, we have the renin inhibitor. So, the renin inhibitor is called aliskirin, in which it inhibits enzyme activity of renin. Next, we have the angina. So, what is angina? Angina is a chest pain or a discomfort caused by an imbalance of oxygen supply and oxygen demand. So, what are the three types of angina? Namely, they are stable, unstable, and variant angina. Diba, we talk about the three types of angina, or the three pathophysiology of angina. We have the stable, the unstable, and the variant. So let us start with the chronic stable angina or the exertional angina. So this type of angina presents as a reproducible pattern of angina that is associated with a certain level of physical activity. And then physical findings are non-specific, and it includes shortness of breath, Tachycardia,
we're talking
diaphoresis,
about is
and
the unstable angina. So unstable angina presents as onset, new onset angina or change in angina intensity, frequency, or duration. And lastly, the variant or the Prince-Metal angina. It involves coronary artery spasm. It has no hemodynamic factors, which appears to contribute to this form of angina. And patients with variant angina tends to be younger and do not carry a risk. Ischemia is a condition in which the blood flow is reduced or restricted in a certain
So the
part
drugs
of the
used
body.
in angina are the
drugs that are used in
angina are the
vasodilators,
vasodilators, cardiac depressants,
vasodilators
and includes nitrates and
nitrates.
calcium
We have
channel
3 routes of administration. So if you want a short duration, you can have sublingual nitroglycerin. While if you want intermediate duration of action, you can have oral nitroglycerin. But if you want long duration, you can have transdermal channel blocker. We can
So cardiac
use
depressants has two
verapamil.
classifications under, and that are the calcium channel blockers and the beta blockers. For the drug under the calcium channel blocker, you can have verapamil, and for the beta blocker drug
drugs,
classification,
we can
you
use
have
metabolism modifiers or
we are going to talk about
is a
heart
condition wherein the heart doesn't pump blood
mechanical
for
syndrome
the
that can
body.
result from any structural or functional cardiac disorder that impairs the ability of the ventricle to fill with or eject blood. So heart failure occurs when the heart fails to pump enough blood to meet the body's metabolic needs. So heart failure has four major determinants, and that is preload, afterload, contractility, and let us first talk about what preload is. So preload is a force that is acting on the venous side of circulation that affects myocardial wall tension, while afterload is the tension in the ventricular wall as contraction or the systole occurs. While contractility, on the other hand, is the myocardium's inherent ability to develop force and shorten its fibers independent of the preload and afterload. And lastly, the heart rate, which is somehow composed of the stroke volume, the cardiac output is a stroke volume. So a stroke volume is the volume of the blood ejected by the heart with each systolic contraction, while cardiac output is the amount of blood pumped in 1 minute. That's it. Next, we are going to talk about the left ventricular ejection fraction, which is the percentage of LV and diastolic volume expelled during each systolic contraction. We are going to talk about systolic dysfunction. So what is systolic dysfunction? So systolic dysfunction is also known as the low ejection fraction HF. It is when LVEF is further classified. We are still gonna use diuretics like furosemide, hydrochlorothiazide, and etc. So furosemide are loop diuretics. So furosemide decreases the sodium chloride and potassium chloride reabsorption in the thick ascending limb of the loop of Henle in the nephron, while hydrochlorothiazide kay ang i-decrease niya ang sodium chloride nga reabsorption sa distal convoluted tubule. And then kaning sila nga mga diuretics is for the treatment of acute and chronic heart failure or the mild angiotensin converting enzymes or the ACE inhibitors, namely the captopril, which inhibits angiotensin converting enzymes, and it is for the treatment of the chronic heart failure, for the hypertension, the diabetic renal diseases, and this drug classification shows to reduce mortality. Next, we have the ARBs or the angiotensin 2 receptor blockers. This drug classification antagonizes all the effects at the AT1 receptors, and these drugs are used like ACE inhibitors, but they are only used if the patients are intolerant to ACE classification of drugs, in which an example of it is melrinone, which is wherein its mechanism of action is to inhibit the phosphodiesterase type 3 and to decrease the CAMP breakdown. It is used for the treatment, or it is used in the clinical application in acute decompensated heart failure, and it increases this drug, which is melrinone, increases mortality in heart failure, chronic heart failure. Next is the natriuretic peptide, an example of which is niseretide, in which it activates the BNP receptors and increases the CGMP. So this drug, it is used clinically for acute decompensated heart failure, but it has not been shown to reduce mortality. Also, we have niproelsin inhibitor, which is sacubitril. Sacubitril is
Atrivia sacubitril is only used in combination with valsartan. So this two, valsartan and sacubitril, is called the ARNI. So sacubitril inhibits neprilysin, thus it reduces the breakdown of ANP and BNP. While valsartan, on the other hand, it inhibits the action of angiotensin on its receptors. Clinically, sacubitril in combination with valsartan is used for chronic failure, and its combination reduces mortality and
cardiac arrhythmia. Cardiac arrhythmia is a problem wherein there is we are going to talk about cardiac arrhythmia. So cardiac arrhythmia is a problem with the rhythm of your heart. So our heart contains these specialized cells. Kanang these cells are able to create their own kanang electrical impulses and isend nila sa mga cardiac muscles which makakause siya og contraction. Then ang katong system or the cardiac conduction system kay naa siya mga 5 elements which is the sinoatrial node, the atrioventricular node, the bundle of His, the bundle branches, and the heart rhythm begins when electrical signals are sent from the SA node. So, ang signal from the SA node causes the atria to contract, in which it pushes blood through the open valves into the ventricles. And in the typical electrocardiogram, it is presented by a P wave. So, a P wave is generated by an atrial depolarization. Next is that the electric signal arrives at the atrioventricular node and is briefly delayed so that the contracting atria have enough time to pump all the blood into the ventricles. And this is represented by the line between the P and the Q wave. And then once it is done, at this point, the signal travels to the bundle of His into the bundle of branches, which is represented by a Q wave. And then, finally, the signal travels through the Purkinje fibers, which causes the ventricles to contract and pump blood from right ventricle into the lungs and from the left ventricle into the rest of the body. And this action is represented by the RNS waves, and the last would be the T wave, which represents the recovery. So what is QRS? QRS is by the ventricular mode depolarization, while the T wave is by the ventricular repolarization. The PR interval is a measure of conduction time from atrium to ventricle through the atrioventricular node. The QRS duration, it indicates the time required for all the ventricular cells to be activated, and the QT interval reflects the duration of the ventricular action potential. Arrhythmia are classified according to the following. We have the class 1, we have the sodium channel blocker. Class 2 would be beta adrenergic blocker. Class 3 would be potassium channel blockers, and class 4 will be the calcium channel blockers. Drug classes is it is by the Vaughan-Williams plus anti-arrhythmic drug classes. Again, I repeat, the class 1 is for the sodium channel blockers, class 2 is for the beta adrenergic blockers, class 3 is for potassium channel blockers, and class 4 is for the calcium channel blockers. Since there are 3 classifications for class 1, A, B, and C, class 1A and class 3 agents, these agents increases repolarization time and the QTC interval and has the risk of TDP. While class 2 and class 4, on the other hand, can decrease heart rate, decrease the force of ventricular contractility, and prolongs the PR interval. Another thing is that class 1B, it is an agent that works only in ventricular tissue. Class 1C are those agents that should never be used after myocardial infarction or with heart failure or severe left ventricle hypertrophy. And lastly, class 3 agents, these agents prolongs the refractoriness in the atria, ventricle, and atrioventricular node. Procainamide. So procainamide is used mostly in the atrial and ventricular arrhythmias. It is for the drug of second choice for the most sustained ventricular arrhythmias, as it is the primary and secondary blockade drug. So another drug from class 1A is quinidine and disopyramide. But quinidine is similar to procainamide but is more toxic as it can cause synchronism and torsades de pointes. And then disopyramide is the same, similar to procainamide, but it has significant anti-muscarinic effect. Next, we have
an example of which is the lidocaine. So lidocaine blocks the sodium channel, and it is used in the treatment of, or it is used for the termination of ventricular tachycardias, and it prevents the ventricular fibrillation after a cardioversion. And next classification is class 1C, which has a drug of flecainide. So flecainide is the same as kanang sodium channel blocker po siya, but it is used for supraventricular arrhythmias on patients with normal heart. But it is prohibited to use in ischemic conditions. Next, we have the class 2 or the for the beta adrenergic blockers. We have propranolol. It blocks ang beta adrenoceptor. It is used for atrial arrhythmias and for the prevention of recurrent infarction and sudden death. It is also under beta adrenergic blockers. We also have esmolol, which is short acting and is used only for intraoperative and other acute arrhythmias. Next class is we have class 3, which is the potassium channel blockers. Example of which is amiodarone. So amiodarone is used for serious ventricular arrhythmias and supraventricular arrhythmias. Next is tafetilide, which is used for the maintenance or for the restoration of sinus rhythm and atrial fibrillation. Lastly, or the last class is the class 4, in which verapamil and deltiazem belongs. So deltiazem is equivalent to verapamil. So verapamil is a calcium channel blocker. It is used for supraventricular tachycardias, hypertension, and angina. Oh, in addition, we have miscellaneous. Under the miscellaneous drugs are the adenosine, magnesium, and potassium. So adenosine activates inward rectifier. It is used for the paroxysmal supraventricular tachycardias. Magnesium is it is poorly understood to interact with sodium-potassium ATPase, potassium and calcium channels. It is used clinically for torsades de pointes or digitalis-induced arrhythmias. And lastly, we have potassium, which increases potassium permeability and potassium currents. And potassium is used for digitalis-induced arrhythmias or arrhythmias associated with hypokalemia. That's it for today. Thank you and goodbye.